Welcome to the For Health's Sake podcast, brought to you by Edito Health, elevating digital transformation with a human touch. This episode is sponsored by Radical Health Festival. It's critical to be radical.
My name is Charles Alessi. I'm Chief Clinical Officer for Edito Health. And welcome to this edition of For Health's Sake. Today, we're going to be talking and discussing aging, something which inevitably happens to us all, something which affects us all, and something which inevitably, as we grow older, we get substantially more interested in. And joining me today, I'm really delighted to have Professor Maddalena Illario here, who's a public health expert and the chair of the European Reference Site Network. Welcome, Maddalena, and I'm very happy for you to be here on For Health's Sake.
Thank you so much, Charles, for this invitation. It's a privilege for me to be chatting with you today.
Thank you. But before we go any further, European Reference Site Network. What a nice name. What does it mean?
You missed the word. You missed collaborative network.
Oh my God, the most important word, actually.
Yes, it is. Yes. It is actually the most important inspiration for our network. Our network was born many years ago in collaboration with other core partners that were got together in the European Innovation Partnership on Active and Healthy Aging to facilitate the exchange of good practices and reciprocally help to build innovative ecosystem at regional level that could strengthen the connection of the local levels with the national and international levels, so that we could have more cohesion of good practices for health, and especially facilitating the exchange of innovative good practices, linking the quadruple helix of innovative ecosystem that are public bodies and organizations like cities, like hospitals, and so on and so forth, private participants, citizens, and non-profit organization, and research. This is the ambitious goal, but we wanted to do our small part.
Well, you're doing quite a big part, actually. So let's just frame this a little bit, because we talk about aging, but you know, it's important for us all to appreciate quite where we're going with aging, certainly in a European context, but perhaps even globally, because if we look to what's been happening sort of from 1950 onwards, every year or so, we've been adding another 18 weeks to the amount of time average people live for. So, you know, longevity is something we have, until recently at least, because COVID put a little stop to this, certainly a change in trajectory, an increase in the number of years that we have lived. And there are two things which seem to be emerging, even though we have been successful at living longer. The two things are appearing here. One, that perhaps there is some sort of limit to this process, because even now, really only about 1 in every 1,000 of us lives beyond 110. So we haven't actually got over this limit, because perhaps systems at the moment seem to break down whatever we do. And also the second concept, which I think we'll spend some time talking about, is this concept of health span, because there is a difference between how long one lives and also, more relevantly, how long one lives in a healthy, productive manner, because what we seem to be doing at the end of the day is, yes, increasing people's lifespan, but also sentencing people, and I use those really emotive terms, sentencing people to a couple of years of misery at the end of their lives, where multimorbidity and everything else that goes with it actually make people's lives not particularly nice. or pleasant to live in. And, you know, we go back to the days of James Fries from Stanford in the 1980s, when he started talking about compression of multimorbidity, compression of morbidity. Wouldn't it be wonderful to live to 104 and actually to end one's life in the flash of a second, you know, in a second, rather than have 4 years of being unable to get out of bed, unable to go up the stairs, unable to go walk the dog?
You know, I think you touched into something that is at the borderline between public health and philosophy, because it depends on how much you value life. I don't think we can say instead of people if they value those 4 years. You know, it depends all on the quality of life, and quality of life is something that changes. The individual subjective perception of quality of life differs. So you cannot say that if you have a multimorbidity or can have limited morbidity, your life is not worthy being lived.
Absolutely.
So I think we should rather change the way we look at it all, and focus on how we can improve the quality of life and improve it as long as possible. But for this, we should start very early. So you touched into the inevitable end of life, which is something that is natural, and there is 25% of elements we cannot control that determine the way we age. But for the remaining 75%, there's a lot we can do as individual and as society. So anything we decide to do, we better do it together, because we can. It's not linear; it's exponential what we can do together compared to what we can do individually.
And if we look, actually, Maddalena, at what's going on, certainly in terms of the science, this is something which has exploded over the last few years. There's an explosion of clinics offering people to redo their telomeres, offering people to manage their epigenetics. So the snake oil salesman, in other words, people peddling less than perhaps scientifically based solutions all over the place. And yes, it is wonderful to go to the Swiss Alps for 3 weeks and be subjected to hyperbaric treatments, to have a swimming pool early in the morning in a hot tub in the middle of the snow. But at the end of the day, I wonder whether drugs which increase longevity in mice would do the same to me, because I'm not a mouse. And I wonder whether the lifestyles which some of the people we hear about, particularly wealthy, successful young businessmen who take all sorts of measures to increase their lifespan and live a really quite interesting life in terms of the amount of food they eat, the amount of exercise they take, but also the rigor at which they address this, and think, could we ever address a whole population like that? So I think the science is moving, and with it the pseudoscience. But the question really is, the science may be moving. The understanding of prevention and managing risks obviously has moved. The fact that if we manage some of these risks, we affect a whole host of non-communicable disease is something we've started to understand. But at the end of the day, have we actually, are we actually within an environment, certainly in Europe with our aging population, where the science and where we're living is the same? Because I think the science is there, but Europe is here. Europe is still living in a world where we work from the age of 25, we get our pension at the age of 67 or 68 or 65, depending which country you're in and the politics. And hopefully you die very, very quickly. So you won't actually cost the nation too much in terms of your pension. But the reality, of course, is these systems are becoming unaffordable because the pensionable years are not being managed as well as they could. So are we where we need to be in Europe, or are we not? We're obviously not. I mean, what's your take on this?
Well, you touched into a lot of very, very provocative things because you started out with the highly advanced sedicenti. I don't know how you say this in English, but the so-called interventions for reverting telomeres and whatever it is, that means that you touched into the probably into what in my side could be some inequalities emerging from the very advanced intervention.
Some inequalities, some,
Some
yeah,
inequalities, and
big inequalities.
yes, and also the literacy about the scientific advancement and effectiveness of some treatments. So this taps into our responsibility as public health advocates to engage the public in changing their knowledge and awareness about what is real about this treatment. It's only business they are looking what they're after. Is it to what are we going against? Because sometimes I think like we are in a big push towards medicalization. This is about it all, because when you propose high cost therapy and propose a therapy for aging, come on, what are we talking about? So it's not that we have to cure aging, we need to improve the quality of life during a physiological process. This means that we have to get real and match it with the three pillars of sustainability for the healthcare system. We need to address health inequalities because this is what underpins unsuccessful aging. And if you feel better if you go on the snow and you feel pampered and taken care of, this is a feeling that should not be just given when you go into the Alps and are into high cost spa treatment. It's something that we could reproduce much cheaper in every step and every corner of our healthcare system, because it's a health system, it's not an healthcare system. It's in the concept of healthcare system is the reactive approach. We need to shift towards a more proactive approach. I underwent myself into a health check, and I stepped into something very, very particular in my hospital, because my hospital is very traditional, high intensive care, everything reactive. But there is this nested place that is managed by a young radiologist, and she created an environment where every person stepping in feels better, because they're trying to do the best out of your experience with your health. So maybe we should look at the way we provide the services, strengthening a number of things, starting from a good information towards all the stakeholders. Maybe, we are not even communicating our data better in the best way towards politicians. They need to strengthen their capacity to take evidence-based decisions concerning our health.
Oh my God, politicians taking evidence-based decisions, whatever next?
We are not good at communicating with technicians.
Yeah.
We are not good, because when I think myself about the politicians, for me it's a whole bunch. They're all the same. So I was preparing a slide some time ago, and I was trying to put a person, a cartoon representing the clinician, the pharmacist, the teacher, and I easily found on the Google a cartoon that was representing that person. But if you look at politicians, it's a question mark, because we think they're all the same. We should take more attention and be more careful to represent the persona profile of the politician. They have background, they have knowledge, they have experience, and we should take more care of how we select the information to give them in a way that they can make use of, and this is something we should dedicate more time, because actually I don't think we are doing enough.
No, I get that, and I agree with you, because of course the whole basis of a lot of what we do is ensuring that we end up in a situation where we personalize messages to individuals, because that's what works. We know that.
Yes.
We seem not to be able to personalize messaging to politicians, who at the end of the day, I mean, joking apart, they obviously have a role within democracies. Of course they do. They do have skills. Of course they do. They do have innate skills around communication. That is exactly what they have, which is what we often don't have. by definition. So there is a complementarity here, which if we engage, we can actually get very much further. So that's a real insight as to something we don't do, I suggest, which we could do. But let's just move this conversation on a little bit and think in terms of the workforce. Where are we with the workforce? Because I am really quite concerned about our workforce. I'm concerned about our workforce because our workforce is either becoming somewhat radicalized in its view, deprofessionalized in some respects, as physicians I'm talking about, and certainly not really in the same frame of mind, perhaps, as some physicians who believe more in these longitudinal, long-term relationships. It's a very transactional process, medicine now, and is becoming more and more transactional. Now, I'm sure people who, of my generation, when I was a young physician, were saying exactly the same around the new physicians who are coming in. They don't do this, they're not as dedicated, they're not as this, they're not as that. But there is a big difference. The democratization of information, the fact that they have lost their ability somehow to feel empowered to really manage a process has done an awful lot to our workforce. Certainly, that's my perception. Is it yours?
Well, yes and no, because for sure we are going towards a less, on one side, a less fragmented way to approach health needs. Because if we want to have a person-centered holistic approach, we need to overcome the silos between the boundaries. And we need to overcome the silos between professional boundaries. This has two consequences. The first one is that we need to involve professionals other than clinical professionals and healthcare professionals. Because if we want to make people feel better, for sure, for example, you need architects, because we can improve ergonomics, you can improve a lot of things inside and outside the built environment to facilitate the healthy choice. And this needs also to be, think about falls prevention, for example. You fall because your house has a risk inside the house. You break the bones because you are osteoporotic, but because you don't see well. You see that this is the pragmatic example of how you need a lot of people to be involved around the health need inside and outside the health system. So this means you have to reorganize the way we train and educate health professionals, but also how we upskill and reskill people on the use of digital tools. So it's a total revolutionary approach. And this means also that we need to strengthen the management skills, management and organizational skills. When you enter even a small, very small, the use of a mobile health app into a diagnostic therapeutic process in an outpatient clinic, it's a small integration, it's huge organizational change.
Yeah.
And the change in the professional identity, it changes the professional identity. People feel threatened in their identity because they identify with an old version of the clinician. That, by the way, what we are looking at, if you look at the approach to revert the rural areas, people running out of rural areas, right? So we need to strengthen services, reskill and upskill people in peripheries of big cities because they resemble a lot in their problems with rural areas. What do we need to do? And for those clinicians, we need to provide a full set of skills and resume the individual capacity to visit the patients with their hands, use digital technologies, use mobile health. So maybe we are looking at a different pattern of development of skills for the clinicians of the future, because
you are more hopeful than me. You are more hopeful. You are more. I mean, a couple of days ago, I met one of the most eminent public health physicians it happened to be in the United Kingdom, but he's a very eminent physician, and he is losing hope, like me, in terms of the newer generations, and he's losing hope I'll tell you why, actually, because it's quite interesting. He's losing hope, not because he doesn't think there is a future. He thinks there is a future, but he thinks the future of the clinicians of the future are going to be so different to the clinicians of today that he doesn't recognize them. And I think he's mourning. He's mourning the loss of
Come on, you can, don't say that, because if you work, I would be working with the students, medical school students. They are extraordinary. They are really believe in their profession. They want to do the better for the other people. They are much better than me when I was a student. I was so
fantastic.
Short-minded, I was lived in my small world. They are open, they're international, they're good, they're dedicated. So I think it's our responsibility to what they cannot do is change the system, because they can do only this much. So there are changes to be done at a bigger level, and they cannot do it. So we need to listen to them and help the change to happen. Don't be scared. Change is good.
So this is good. This is good, because what we're getting to is a place where there is more hope, perhaps, than originally appears, which is good news. But let's move a little bit to the systems we live within. We live within a system which, you go to school when you're a child, you then go to university or not. 90% of people now go to university. You end up with a profession or a trade of some sort. You work for 40 years, 45 years, at the end of which you retire. How does this fit the new 100-year life? Because I don't think it does.
Why aren't we talking about reskilling and upskilling retired people? I'm already planning to be reskilled and upskilled after I retire, because I'm sure I will be doing something. But I'm not sure I want to keep working in this part of the public health system. Maybe I want just to go to work in elementary school. I don't know. I want to garden. I don't know what I'm going to do. But I want for sure to be reskilled and upskilled. So we should focus on this population of older adults, because this would help make them productive and engaged. And also we don't lose their heritage. It's not only heritage, it's really content. They have a lot of knowledge. So how do we preserve that knowledge? In my previous life, I was doing basic science, and in science lab you have these protocol books, and in the protocol books you try to standardize the experiments and what you do, but it's very hard to have all the knowledge closed in the books. When you lose a human resource because they leave the lab, there is a package of knowledge that leaves because there is not enough AI. We can code this knowledge. So a lot of knowledge is linked to people. So if we keep the older adults as long as possible into a place where they can still give what they know and exchange it in intergenerational activities, because they can reskill and upskill themselves to help reskill and upskill 45 years old, 35 years old. It's a chain of a virtuous cycle.
And we're losing big opportunities, Maddalena, because what we're doing is we're losing people with a memory.
Oh, God.
We lose that. We're losing people with the ability to actually mentor younger people. We're losing. I mean, I teach some medical students, and I have mixed feelings. I'm not totally optimistic like you. I'm also a bit pessimistic on occasions. But anyway, if we look to what older clinicians can bring, that level of experience, knowledge, is something which you don't get.
But it's a cultural change, because everybody feels threatened by change. Now, can you imagine we have all this massive stress in the society. I'm very deeply touched every time I hear of some young adults committing suicide. Nobody talks about it, but this is a tragedy, and it's a failure of a society, because nobody can prevent it. Nobody realizes this.
Sorry, people can prevent it.
It can be prevented, but you need to have a different level of attention, of sensitivity. Yes. You need time, and most of the time we are overwhelmed in our life, and we don't have enough time to listen, to be sensitive. So maybe even older adults could also provide this kind of dedication of time to listen and be included in this kind of attention, of sensitivity to the other, you know, at all levels of society. I don't know, I may believe in my own world.
No, you're absolutely right. And I think let's just take one last thing I want to talk about today. And I want us to end this conversation not on a positive note, on a realistic note around what's missing, perhaps. Because, of course, we talked about workforce, we talked about the importance of actually changing the systems that we live within to ensure that people can have as productive a life as possible. But it's really important we assist the carers of tomorrow and of today to be as prepared as possible to help people through their life course. And I talked to you and we were smiling together when we had a previous conversation about the need for us to develop an unmedical school.
Yes.
And I think it's such a fun concept, the unmedical school.
Yes.
And the unmedical school is basically an opportunity for us all, as we grow older, to understand that a lot of the things we didn't learn in medical school were the things we really needed to understand.
Yes.
The issues around behavioral health, the issues around the importance of relationships, communication. It's not only about all the arteries and the divisions of each arteries and the names of the arteries. So I think a little bit of thought around the unmedical school would help us all. How are we going to make this happen?
You know, I think we need to strengthen the integration with the social sector, because social isolation, it may not seem related to the unmedical school, but indeed it is, because you learn that dealing with other people, keeping friends, keeping relationships takes time. It's something that takes your time, and it is something you build over time. So you want to dedicate your life to help other people, and you can build a network around, a social network around people, and this is where the unmedical school can be integrated. Be careful, social needs doesn't mean that they don't require professionals. You know, it's a different professional skills than the skills in medical school, but you learn it only when you start working in an interdisciplinary environment. That's why it is related since the ground. You need to teach it in elementary school, in kindergarten. How do you relate to the other? You know, the dialogical, there is an Erasmus Plus project we are working in, it's the dialogical approach. It was very hard in the beginnings because you need to take time to listen, a different way to look at things and to listen to people and to react. But it is something you must be trained, and you are trained in the family since you're born, you are trained in elementary school, you are trained in high school, at the university. So maybe we should, you know, but if you will live in a system where medical schools are still accredited, counting the beds, that's something that is not going to help, because the dean of the medical school and the rector are going only to focus on how they can cut a deal with the region. Counting the number of beds.
Yeah, if it's all about beds, if beds is the currency, I'm interested in beds.
What is more medicalized than a bed? So if we are going, I really, this is something we are living now in our region, in our medical school, and in Italy. So if we are still, this is not politically correct, something is going to kill me, but still, if we are living a digital transformation of health and care, do we trust ourselves if we are living it in the middle of a place that still counts performances on beds? So this is a push towards medicalization instead than rather the opposite. So we are, you know, it's a country going this direction. It's really unbelievable.
Mind you, but we're all in the same place. And when you talk to the leaders of systems, when you talk to people responsible for public health at major level, I think there is a degree of consensus around where we need to go. There may be disagreements around the way to get there. Of course, there will be. That's fine. But when you then transpose that in the environment we're living in, there is a real dichotomy here, because we talk about one thing, but actually do something fundamentally different.
Yes.
So I think our role is really, to show that we need to change that, but also to help change it. And by the way, I include within that your medical students, my medical students, the students who you say are so, they need the system changing for them. I would suggest they need to be part of the solution to change the system, because we can't change it on our own. We need their help.
Yes, there are, I think that there is for example, there are medical technical schools that should bring together engineers and medical school students. But how do you organize the training content? How do you organize the credit? How do you organize elective didactic activity? It's a radical change. It's really profound and deep, because you need to change the mindset of the professors, of the researchers. The mindset should be person-centered, proactive, engaging students, not being scared of integrating their suggestions. It's not about it's a service model. You need to change totally the approach. I mean, it's a huge effort.
This is radical. This is subversive. This is
I know, and
news.
you constantly swim against the wave. It's like so tiring sometimes. But
I think we're getting there. We're getting there, Maddalena, because actually, not only are we talking about this far more than we used to, we couldn't have had this conversation 10, 15 years ago, I think. But also, we're seeing some changes. There are now some medical schools which are actually really trying to integrate the different body parts of sick health into one part to become more functional. That was completely out of the question in the past. So we are moving to the right sort of direction. So listen, we've been talking for about half an hour. So I think we are in a situation where we have really delved a little bit into this, but we're going to be delving into this far more, of course, at the Radical Health Festival this May in Helsinki, 2024. Because if we're talking about precision and prevention at scale, we're talking about personalization for the individual, for populations, around ensuring we manage to give them as full and allow them, give them, it's not for us to give, it's we enable them to live as full and a life as possible according to the rules which they themselves determine are the things which make them feel fulfilled. And I think that's really what we're trying to do at the end of the day. So I want to thank you for spending a good half hour with me today for us to have this conversation. And I think we'll continue this conversation a little bit more, as long as we continue being radical in what we think and not being afraid to call things out when they're not working, like we have.
Yeah, thank you so much. I think what international collaborations do for the local level is help you thrive against the tide. So this is really important. It's like a breath of fresh air, because you don't feel you are the only one. But you are with someone else that is like-minded, and maybe together we can still progress.
And we usually can do something far better if we have somebody who's helping us and pushing us a little when we get tired.
Absolutely.
Which is exactly what we're doing today.
Yeah,
so
that's why
thank you, Maddalena.
Thank you so much.
We see each other very soon.
Yes, thank you so much. Bye, Charles.
Bye.